My job involved a lot of climbing, and I was constantly on my feet. So maybe at my age, things started to wear out. And you don't have to be a rocket scientist to clearly see that there was no cartilage in my right knee and a quarter of my cartilage in the left knee.
Hi, Dr. Zann.
Yeah, again.
Okay.
Alive and well. That's something good.
I'm good because of you.
Patient comes in with bilateral arthritic knees. By and large, that is something that they inherited. So you'll find that there's two patterns. Pattern number one is there'll be a bow-legged pattern. Pattern number two, there's a knock-knee pattern. Nobody seems to know why. Knock knees used to be associated with inflammatory disease like rheumatoids and lupus, but now we're seeing them routinely. Bow legs, on the other hand, we used to think was a wear and tear phenomena.
Walking was my biggest problem. I couldn't walk prior to the surgery the distances that I used to be able to walk without pain. I had to stop and rest more often. I learned to tolerate it after a while, but I always thought it was arthritis.
Typical complaint for knees is A, pain. Pain's the most common complaint. 2, the knees are getting deformed. They're looking down, they're seeing things that don't look normal, even though they're not hurting that much. And then 3, the knee will start buckling on them and fall down. And once they start falling down, bad things happen. Knee replacement is not a pleasant operation. However, what's happened in the last year is we now have a pain management program that was started last March. Now, when you talk about a multimodal pain management program, multimodal means there's several parts to it. Number one is you have to address the pain. Now, pain comes from locally from the knee, then to the spinal cord, and then eventually to the brain where you perceive pain. So if you block the pathways in any of those levels, this is a different modal approach, so multimodal. Obviously, doing a spinal, you're going to block the pain from the back. When you use oral or IV narcotics, you're blocking the brain impulses that give you the sensation of pain. The last thing, which we finally put this picture together, was we now have some medications that we can inject directly into the knee at the termination of the case, which are gel-bound, it's called Marcaine or Novocaine. And what that does is that'll bind the substance and slowly release it over the course of the next 72 hours. That's been one of the greatest breakthroughs that we've had. I do everything, if I can, under IV sedation, followed by nerve blocks. And the reason why is if you block the nerves, not only are you taking care of their pain initially, but that nerve block can last for 48, 72, up to 72 hours. So you're giving the patients a tremendous amount of pain relief, allowing them to get out of bed the same day, dress in normal clothing, have private rooms, have therapy twice a day. 25% of patients are now going home on day 2. The remainder of them are going on day 3. 90% will be going home. 10% still require a rehab center only because they have no family, they have nobody to take care of them, they're scared, they have multiple medical problems. There's a lot of reasons why people don't want to go home. Alignment of a knee is, first of all, you have to know how to do a total knee. That's number one. The alignment systems that we had will go back to the original, by today's standards, antiquated systems in the 80s. But if you knew how to use them, if you knew how to use them properly, almost any good surgeon could align a knee so that it was within 3 to 5 degrees of perfect. Now we have the benefit of computers. So we now have computer-generated technology. So when we do our knees now, we're able to go into the operating room with a computer, with a navigation tool, that more or less confirms the exact placement of those components. This, you don't have to pin it, so you don't run the risk of sustaining a fracture to your bones. That's a problem if you have to put pins in people. You try to minimize how much trauma you're doing to the bone as well as the soft tissue. Now this device allows you to be within literally a degree or two of perfect almost every time. We've had our x-rays reviewed. And our x-rays, every time we look at them, I'm constantly amazed because I can't find any problems with it. I mean, if you put them in perfect, they should last 30, 35 years. So the value of it now is that not only do we know the cuts are going to be perfect, but you can make smaller incisions. Now, smaller incisions equates into less trauma to the tissues. So that, again, benefits the patients.
People in the hospital, you did 2, wow. You don't have a leg to stand on. And I'm just happy I did it too because I didn't want to come back a month, 2 months, 6 months, or a year later and start this whole process all over again.
That's an absolutely stable knee. That's as good as it gets.
Doing my exercise, I was told weight-bearing exercise are probably the best thing I could do. They tell me I'm doing good. I'm very happy with the outcome of it, but I know it's a long road ahead, and the rest is up to me.
Thanks, Dr. Zann.
Pleasure,
Really
pleasure,
appreciate it.
pleasure.